Okay. Good morning, esteemed colleagues and distinguished guests. First of all, I would like to thank Ajahn Tharati for this kind invitation, and it's a pleasure to join this conference. And the topic I will be speaking on is continuation from the previous one presented by Ajahn Rapipat. He is already provided important details a lot. Okay, I will be presenting the content regarding the outflow control, which composed of these topics. Let's start with the approaching the hepatic veins. The major hepatic vein is useful for left liver resection because it diminishes disorientation. Accessing the hepatic vein, especially middle hepatic vein, for guiding accurate transection plans. The approaching techniques for exposing major hepatic veins depend on various factors, including tumor location, hepatic vein anatomy, and the expertise of the surgeon. Each approach comes with advantages and disadvantages. Careful evaluation should be considered to minimize hepatic vein injury. Various techniques have been developed for hepatic vein guided approaches. For the hemihepatectomy, we might prefer to do the dorsal approach and score the device from the root to periphery, like this. The major hepatic vein it should be approached with this side because it helps to avoid splitting injury that can occur if you score the device or approach from the caudal view and prevent the pull-up injury. Moreover, the dorsal approach can the blood run down from upper to lower part of the liver, maintaining a dry transition line of the upper part. Knowing the anatomy of the middle hepatic vein is crucial in performing hemihepatectomy. It could enhance the safety and efficacy of the procedure. This study conducted in 35 healthy living donors at Kyoto University by using the 3D reconstructed in Synapse software showed the middle hepatic vein and its tributaries. The midplane was identified at demarcation. Along with this plane, the investigator demonstrated that the middle hepatic vein gives fewer tributary from its anterior and posterior aspect, at which lower than from the right and left side. Moreover, tributaries from anterior and posterior aspects are smaller in diameter with the median of only 2 to 3 millimeters, compared with 4 to 5 millimeters from the lateral ones. To apply this knowledge, middle hepatic vein dissection should be done from the AP aspect, poses a lower risk of injury to the tributaries compared to dissection from the lateral aspect. Additionally, dissection from the AP plane allows safe identification and isolation of the thick tributaries originating from the lateral aspects. This picture shows the V4, 5, and 8, all of them branching from the lateral aspect of the vein. This picture shows the simulation of the virtual right hepatectomy using pooled data from preoperative CT scan of 40 patients and simulating on the Synapse software. The results show that median of 3 tributaries larger than 2 millimeters come from middle hepatic vein, with a median of 1 branch of V5 and 2 branches of V8. Primary tributaries directly drain into middle hepatic vein, approximately 80% draining into right liver, draining from the right liver, and the median diameter is 4 millimeters. This simulation demonstrated that proximal middle hepatic vein tributaries can be identified when beginning a parenchymal transection with a median of 16 millimeters above the hilum and 22 millimeters caudal to the portal tongue in the liver hilum. In association with this knowledge, the dorsal approach to middle hepatic vein from the hilar plate can be done as a shortcut method. This demonstrated by Professor Kim published in February this year. After dividing the liver parenchyma along the midplane or the demarcation line just above the hilar plate, the middle hepatic vein route could be easily identified. V5 and 8 were found and controlled thereafter. This approach could be applied in both right and left hepatectomy. For the left hepatectomy, After dividing the liver parenchyma along the midplane, starting from the hilar plate at the same method, the route of the middle hepatic vein was exposed easily, and many of the 4 hepatic veins were controlled, and transection plane is very clear. This is the middle hepatic vein, which can be identified nearby the hepatic hilum. As mentioned earlier, moving the tip of CUSA along the posterior or anterior aspect from the root to periphery by dorsal approach could help to prevent the injury. This is a retrospective study from the CT scan demonstrating the variation of middle and left hepatic vein according to Nakamura and Suzuki classification. Of 102 examinations, 70% of the left and middle hepatic vein combine to form a common trunk, empty into IVC. The common trunk had a mean length around 9 millimeters and mean diameter of 2 centimeters. Only 26% of patients had individual venous drainage from the left liver. According to this knowledge, care must be taken when we control the left or middle hepatic vein or the common trunk. Let's move to the liver mobilization and hepatic vein control. This video shows liver mobilization by the caudal approach. The short hepatic vein branches could be ligated and divided at this time. And for the small short hepatic vein or the vasa vasolum can be sealed and cut with the energy device. Mobilization of the liver from retroperitoneum and IVC should be done both lateral and anterior aspect of the IVC. This could facilitate the exposure during the procedure. And we may stop after identifying the hepatocaval ligament and the inferior part of the right hepatic vein. This process could enhance the right hepatic vein control after parenchymal transection. This is the hepatocaval ligament and the inferior part of the right hepatic vein was shown. If there is an inferior right hepatic vein with a big and short trunk, we may dissect and control it after parenchymal transection. It is safer to do after the parenchymal transection and we get a longer length to control. This video shows the right hepatic vein control method after parenchymal transection. The liver tissue and connective tissue covering the IVC was open. After trying to dissect anterior aspect of the IVC, the root of right hepatic vein was incidentally injured. Care must be taken during dissection to control the root of hepatic vein. Firstly, the right hepatic vein drains into the IVC in horizontal plane. It is better to dissect to encircle it from the lateral aspect of the IVC instead of doing anteriorly. Second, there are 2 layers of Lennox capsule attached together in the area between liver parenchyma and the hepatic vein root or IVC, called the hepatic and cardiac Lennox capsule. The cardiac Lennox capsule covers the tunica media of the IVC and right hepatic vein. Injury through this connective tissue can penetrate the vascular wall and bleeding occur. Let's move to the left lobe mobilization. This is a patient with IPNB in lateral section with chronic inflammation and atrophy of the segment 2 and 3. And this is the inferior right hepatic vein, which is the landmark to approach the suprahepatic IVC and the root of hepatic veins. After mobilization of the coronary and triangular ligament, both sides of the inferior phrenic veins were identified. That is the right inferior phrenic vein, and the suprahepatic IVC was exposed at this start. The ligamentum venosum or Allanchius ligament is an anatomical landmark utilized during left hepatectomy. Following the division of lesser omentum, the Allanchius was found connected with the omentum. The cranial end of Allanchius attached to the left hepatic vein, and its caudal end attached to the left portal vein. Dividing the laryngeus could facilitate the exposure of the left hepatic vein, including the middle hepatic vein or even the common trunk. The laryngeus is also the important landmark for safe inflow control of the left hemilever. This video shows the procedure after inflow control and nearly complete parenchymal transection was done. So at this time, I move, oh, sorry. Okay. At this time, I move to dissect the laryngeus ligament and cut it, and move back to dissect the liver parenchyma, cut the left hepatic duct, and move back again to control this is the weave through entry drain to the root of the left hepatic vein. But it drained outside the liver parenchyma, so I decided to control it individually. But because it's very short, so I decided to control it with a hemolog, double hemolog, and clip on the specimen side. It's safely controlled. And this time we can completely see the left hepatic vein and control it safely. Before filing the staple, we have to ensure that the vein was controlled entirely. However, after filing, the equivocal completion of the staple line was concerned. It was controlled with clip before dividing. Hanging manual can facilitate the outflow control during laparoscopic major hepatectomy. It is useful to guide the transection plane and to control bleeding in the deeper parenchyma. According to Professor Kim's publication, after dissection of the left triangular ligament, and he proposed to just create only a centimeter hole on the left side of the left hepatic vein. We could insert the hanging tape into this hole lateral to the aspect of the left hepatic vein. The superficial parenchyma of the ventral and dorsal area should be created, should be done to create a groove. And the position of the lower end of the tape was then determined according to the left side hepatectomy type, including the lateral sectionectomy, left hepatectomy, or the extended left hepatectomy. The hanging tape is then aligned along the laryngeus. During the laparoscopic left hepatectomy, the transection plane is initially vertical, but deeply during parenchymal transection, the plane follows the laryngeus and becomes horizontal. The hanging manual renders this horizontal transection plane vertically. This is my first laparoscopic lateral sectionectomy, maybe a long time ago. At that time, I was struggling with the parenchymal transection because the CUSA was not operable. I used the gold finger to perform the hanging technique to enhance the direction of the transection plane. Regarding the lap right hepatectomy, after mobilizing the liver caudally, Professor Kim also proposed a modified hanging method by inserting a tape along a plane locating between the right adrenal gland and the IVC, as shown in this picture. With the same method of the left side, a hole was created on the right side of the right hepatic vein. A catheter was inserted in a cranial to caudal fashion. By this technique, it is unnecessary to dissect a groove between the right and medial hepatic vein and the plane anterior to IVC, which avoid the injury and bleeding. The last topic is the firing staple technique. To fire the staple, we need to prepare the instrument to control and encircle the hepatic vein root, including the endoretract, gold finger, and vascular tapes. It is also necessary to have the vascular clamp to control the vasculature, in particular in case of bleeding from the major vessels. We need to control it immediately before applying clips or suturing. This video shows the staple technique of the left hepatic vein. This operation was performed during the early period of lap hepatectomy by Dr. Varakirti, who is currently the main lap donor hepatectomy surgeon at our hospital. After firing the staple, bleeding occurred due to fire failure of the staple line. Notably, the patient had liver cirrhosis, and the root of left hepatic vein was controlled with some liver tissue intact. Here you can see the bleeding point from the failure of the staple line. So one factor should be concerned before filing is complete removal of the liver parenchyma surrounding the hepatic vein. Consider compression longer if some parenchyma intact. By compression technique, caution needs to be taken in the cirrhotic liver, which may cause incomplete compression and leads to failure of the staple. Moreover, the size and type of the staple is also crucial. To facilitate the appropriate manipulation of the staple, the operating port and camera port side may be need to switch between the umbilicus and the upper abdomen, and the staple device should be chosen in an appropriate size as well. Before firing, ensure if the staple line completely cover entire the wall of the vein. Conclusion. Hepatic vein is the crucial landmark during the left liver resection. Is it better to expose middle hepatic vein from the dorsal approach, starting from the hepatic hilum along AP aspect, then dissect to control the tributary coming from the lateral sides? Avoid the splitting injury by moving the device from root toward periphery. Consider reviewing the anatomy of the hepatic vein before doing the operation. Identify and dissect the ligamentum venosum to enhance the precise direction during left hepatectomy. And consider using the modified hanging maneuver to facilitate parenchymal transection and outflow control. This technique can help to navigate the transection lines and preventing or controlling the bleeding. And actually, we need to prepare the prompt instruments and clear the staple line before firing. Thank you for your attention. And lastly, I would like to take this opportunity to promote the upcoming APHPBA 2025 in Bangkok. We are looking forward to welcoming everyone. Any suggestions are welcome. Thank you.